All right, here we are again for another Down Fracture podcast, which is a podcast for talking jaws. Per usual, this is Dr. Michael Wasson of Arizona Jaw Surgery here with Dr. Bobek of Seattle Jaw Surgery. How you doing, Sam?
Doing good, Mike. 18 is my number.
All right,
18 patients. So we're talking about TMJ replacement today, right?
that's the plan and some of the misconceptions that kind of go on with this. So first and foremost, our housekeeping, downfracturepodcast at gmail.com. If you want to email us potential topics or cases or anything you want discussed, feel free to do that. Of course, protect your patient information if that's included. And then, we were just talking before we recorded as maybe emphasizing why people should listen to us. And I'm not sure they should. I don't think you and I would ever necessarily say people should listen to us, but I think it is, especially in this topic, maybe important to know that this is not something you and I are just like sitting on the sidelines on. You and I both see a lot of TMJ patients, do a lot of TMJ surgery, do a lot of TMJ replacement. Um, that's something that people maybe would want to know. I would say it's an unusual day in my practice when I don't see a TMJ patient. How about you?
Yeah, no, I mean, I think you and I both practice in a way that we do orthognathic and TMJ surgery. And so that practice is I don't know, I think it's the right way to go. I feel like I don't know how you do TMJ surgery without doing orthognathic and doing orthognathic without TMJ. So those seem very connected topics. So we
Absolutely.
definitely have been living in this world for a while.
Yeah.
Our our topic, I think, is one that can, rise some passion in Dr. Wasson, which has to do with some misconceptions of TJR. So
I have been guilty of getting riled up and wanting all the smoke, as the kids would say, when it
yeah,
comes
I've
to
witnessed that actually. Yeah, so I've seen some grand rounds. Your cowboy hat, or just like your eyes getting a little big. I feel like there's it's going to be 2025 this week, right? And
is.
I think in many places, TJR is still an unknown entity, and it's thought of as investigational and not good data. And I think this is at least my perception. I think that's what rightfully gets you fired up, right?
That's absolutely part of it. And I think part of it, our perspective when you start talking about the surgeon in TMJ is we clean up a lot of messes, is the way that I sometimes phrase it. And I'll be the first to admit some of them are my own. I'm not perfect. I have my issues, my complications. None of us are perfect all the time. But, I audited my results because of an assistant one time in Seattle. I just had an inquisitive assistant, and we audited basically our results. And we found something that I still will, when I lecture, bring up. And we audited it over the course of a year, how long patients had been in TMJ treatment before they saw us, how they found us. And then strangely, the one that I wanted to add was the number of splints that they had. And in our practice that year, it was about 75% of the patients found us on their own. So, I mean, think about that just in nature. Like, these patients aren't being referred for TMJ surgery or TMJ replacement. And the average split was just shy of 3.5 years in treatment, was close to 5. It's kind of, I think we see the sad stories. And I think that's part of where my emotional, visceral response comes from is I think it's a frequent occurrence that I see a total joint patient that was an arthroscopy a few years ago that is no longer an arthroscopy. And I always find that somewhat heartbreaking almost for the patient. I don't know. What do you feel about stuff like that?
Well, yeah, I mean, I had someone recently who she was in her 60s. Um, and she had a rib at Children's when she was a kid.
Well,
And she didn't think anything existed to help her out. And she had full-on ankylosis. I mean, malocclusion, ankylosis, and she was unaware. And didn't spend a lot of time online, it seemed. But I mean, her practitioners, primary care doc or general dentist, um, were unaware of these interventions. And I know there's people still out there today that don't know this exists or think it's um, really not mainstream treatment.
yeah.
So Because I mean, it's like anything. I mean, when I came to Swedish, by the way, so I like telling stories. I came to Seattle a decade ago, and I came from Portland. And in Portland, TMJ surgery is a bit of a normal thing, and then in Seattle, it was an abnormal thing. And I showed up at this hospital that did a lot of jaw surgery, or I'm sorry, a lot of jaw surgery had happened at this hospital for decades prior to me showing up, and they seemed unaware of TMJ replacement. They had done one or two, maybe over the course of 5 years. Um, and I come in and I find it to be a useful thing. I think it's a good operation.
Right.
Um, and so that wasn't that long ago. So I feel like there's certainly spots in America, and I can only imagine in other countries, it's you're still getting recommended to just deal with it. So
Yeah, it's sad. Well, yeah, I think that's number one on our list. If anyone's actually watching the video of this, and number one thing that we put on here, then not necessarily in order of importance here, is that it's an investigational or experimental treatment. And I think, I again, in my 15 minutes of preparation before this, I did screenshot some articles here, and I think one of them is a kind of a really important article that came out about 10 years ago about the longevity of the devices. And I think this speaks to a number of the misconceptions here. And then, I want to hear your thoughts on it. But that's a common question that I get in my practice, or misconception that I have to dispel in patients or residents or students, is that's the longevity of these devices and are they experimental? And 10 years ago, Mercury and Wolford and others published this paper of 20 years of follow-up, and that was 10 years ago. And I think the important points that I took from this, and I'd be again interested, want to hear your thoughts on it, is they kind of somewhat contradictory, or I guess counter to other prosthetic joints in the body and knees, hips, shoulders, other things, is found that they really weren't finding a time point where we were seeing these fail per se. And that was up to 20 years of data, which now, if you talk to these people, we're at close to 30. And even at the 20 years, some of those people had some that were 23, 24 years because they started placing them in 92. And so we're finding, we basically, the take home message was there wasn't a time point where they started seeing failures take a big leap.
I have a
I think that's an
suspicion
important
of
thing.
why because I don't know. I think I agree with what you're saying. I can't believe that paper is 10 years old. I feel like I just feel old every time we meet. But um, any discussion of TJR, you can't forget about the 80s, right?
Yeah,
The 80s, I think,
disasters.
combined with the relative limited interest in surgery, which those things are likely connected.
Oh yeah,
That modern surgeons don't have it's unusual to have an interest in TMJ surgery. Um, I think that combination has kind of led to people being unaware of TJR. I mean, I assume everyone who's listening to this knows this story, but in the 80s, late 70s and 80s, there were devices being made um, and used for TMJ replacement that didn't have appropriate workup and outcome data, and they made people worse. They really were bad devices, and there's a lot of information online about it. I think patients that went through that time were harmed, and those patients are still around. They had a hard go. They had it was a difficult thing to go through because I mean TMJ replacement was just kind of starting then, like 70s and 80s, and the devices that were being placed made people uniformly worse. Um, and so when they were withdrawn from the market in the 90s, and the FDA withdrew all devices in the 90s from the American market, and then they followed everyone, for whatever it was, the 10 or 15 years. FDA follows people, I think, still. Um, we got down to the two devices that exist. And so it was like really rigid. You went from like almost no oversight to ultra rigid oversight. And people, I don't know if they know how much oversight there was. And so there's actually really solid data because the two devices that exist, the Biomet device and the Stryker Concepts device, TMJ Concepts,
in the U.S. Yeah,
those have been around since the 90s. And I mean, 90s are, again, I don't think that's that long ago, but I mean, 30-year data on devices is good, particularly in comparison to the alternative.
right.
And I think we both know the alternative, which is rib, fibula. nothing, or toe. And all
Clavicle,
those are bad
tried
alternatives.
clavicle and like some other things at times. Yeah, it's
Yeah, I bet you clavicle probably should be above toe. I just like mentioning toe.
yeah.
In Portland, they used to do those sort of things. Did you ever get scrub into toe toe graft?
Never a toe, thankfully.
Anyway, but the history of it, I think, is part of the reason why, practitioners, particularly more senior practitioners, likely learned in dental school that these things are bad. Like if you went to the dental school in 80s and 90s, you would have learned that, right?
I think they still learn it, to be honest with you. I think they still learn,
What
some of
did
the misconceptions that we
what'd
have.
you learn in dental school?
What's that?
What'd you learn in dental school?
That these were basically a last resort,
Yeah,
like that you exhaust all possibilities before them. I don't remember learning that they were like inherently evil, like some people believe, but as someone who went to dental school 8 floors down from Larry Wolford, it was surprising what we were taught and how little we were taught and some of the misconceptions we were taught.
sure. Yeah, because I mean, I think we were talking about it before we started on. There's patient advocacy groups, which are great. Um, but part of it is that there's some I I don't know. And there's different education that people have for TMJ management, right? Like continuing education, different background education from dental school or residency, whatever courses they've been going to. But I think people get lost in internal derangement. I think TJR is best understood as there are clear interventions outside of internal derangement, right? Like when people say, "Oh, there's TMJ treatment," I think generally people are talking about internal derangement treatment.
or
And
or muscle disorders even.
oh, exactly, yeah, yeah, like um, and that's the majority of quote unquote TMD. But there's clear indications for TJR outside of that I don't think are controversial whatsoever.
But it
And
should.
most of the time when I give continuing education about this sort of thing, I try to start with that just because I think we can all agree on that, right? I mean,
Should
some
be
of
able
them,
to,
right?
man. I mean, we should be able to. You got ankylosis, you got a tumor. The extremes are always somewhat simple, but I think there are some ones that shouldn't be controversial that people still view that way. You've got degenerative joint disease and malocclusion. For me, that's a clear and obvious indication for total joint replacement because anything less is unpredictable, right? Okay, what are we
I
going
mean,
to
I
do?
would challenge you a little bit on that. I mean, I feel like it would be a matter of degree.
Oh, of
And then
course.
the person that's there, if it's longstanding resorption from whatever their teenage years and they're
I
whatever
mean, let
down
me
the
back
road asymptomatic, I
let
have
me
a
back
hard time.
let me backtrack that a little bit because I do think
Yeah,
words are important. Someone with a skeletal malocclusion with degenerative joint disease is a candidate for total joint replacement, and I don't think that's controversial. Is that the only treatment option? No, I think you can go other ways,
sure.
but I think that patient should, in any reasonable discussion, should have a discussion about total joint replacement in that scenario.
Yeah, for sure. But
That's
here we
still,
go. We're jumping right on like disagreeing with each other rather than agreeing. I think a ton of us, honestly, I feel like most people who treat TMD patients would agree that ankylosis should be treated with TMJ replacement. I mean,
I
gap
hope.
arthroplasty and fat graft or temporalis flap or rib. Come on, it's 2025. Occlusion is not going to, I mean, scarring is going to happen. I mean, if they're absolutely contraindicated for some reason, like infection or I'm not sure what would happen.
Some kind of bizarre metal reactivity.
Like they were radiated. I'm not sure, right? So sure, I could get on board with that. But I mean, ankylosis for sure, failed device for sure, right? I mean, arguably a failed rib.
Yeah,
That's pretty straightforward. Any tumors, not any, but most tumors, pretty easy.
yeah.
There's a lot of congenital deformities like hemifacial microsomia. It's pretty straightforward. I'm not saying in kids, even though,
Heterotopic bone formation, if you want to throw that as a separate than ankylosis, I
yeah.
think that's
And I think that I know there's others, but I think generally everyone would be like, hey, that's reasonable. Like, even a fractured dislocation of a condyle that they didn't do well with conservative treatment. Um,
I want to
Time for
believe.
joint replacement.
I want to believe, man, but here on our list is last resort only, and I hear that all the time. and mostly it's from other practitioners.
No, I do as well. I do
Yeah.
as well. And
I would love to say that I'm in agreement with you, and those are clear cut, obvious. I agree with you, but if you're saying that those are clear cut, obvious in the community, I would say, man, I wish. I think
well, I think again it gets lost in the internal derangement thing because, I think we both hear, and I mean, I'd probably agree with this more than you would that surgery isn't the first line treatment for internal derangement.
yeah, I
I
would
know you
disagree with you
disagree
there.
with that a little bit, right?
I would.
Yeah, but I mean, I think when people are talking about surgery in general for TMJ surgery, TJR is in that. And so TJR, though, excels at some things. And it is by far the most predictable TMJ surgery
No doubt.
uh, that I can do.
And definitive, right? I mean,
I don't know. How long did it take before you were convinced of that?
that it's a very before it's which part do you mean?
That's predictable.
Oh man, no, it didn't take long at all. I in some ways I prefer it over orthognathics, and I've told you before, like I just always feel like orthognathics, there's just a little wiggle. I can't count the number of patients who you have in the operating room, and you're checking them their bite and the splend, and things look good, and you sew them up, and you go about, you see them at 1 week, and they're hitting only on one side or premature contact, and if you just do joint replacement, I find that just does not happen. If
Well,
you
because I think what we're talking about is another clear indication. I think we could get people on board with it. Um, which is, when you're doing TMJ surgery, one of the problems with TMJ surgery, and I remember getting this feedback from residents, and I thought this way as well, and I still do, I guess, is that sometimes it could be unpredictable, right? You're trying to
oh,
do the
I hear
least
you saying.
invasive intervention.
Yeah,
You're wanting them to send off to PT, and you don't know really how they'll do with PT or arthrocentesis or surgical arthroscopy or an open arthroplasty with disc plication or discectomy. Whatever procedures you're doing. Um,
so you
there's
said
some that
predictable.
are unclear outcomes, and you don't want to have an unclear outcome, right? Like
Yeah,
you want to feel
yeah.
really good about how they're going to do. I think the reason that that's the case is a lot of times we're forgetting about parafunction, and kind of the engine that's causing the derangement or the difficulty with adapting to the derangement. Um, but with TGR, it just kind of derails that process. It seems to be the most definitive. It's just that, there's downsides to it, right?
Yeah,
So,
absolutely. No, that I think I have a better understanding what you're trying to say. Yeah, absolutely. Because I'm fond of saying to patients and other referring providers, and probably said it to you, there's times where I go do an arthroscopy and I'm like, man, that was a good one. I got in there, I did some work. I broke up a lot of adhesions, I did my anterior myotomy or whatever I'm doing. And they won't respond well. And
no,
they'll have some that it's a struggle. I'm like, man, I could hardly get in there. And when I was in there, I couldn't instrument well. Maybe I didn't even get to the anterior recess sometimes, and they will thrive.
yeah,
It is just sometimes like I wait for that 1 week and 3 week follow up. I'm like, I don't know what I'm gonna get.
because
It's
I
the
thought
day
that
after
would
tomorrow.
I thought that would get better with reps. I
Yeah,
mean,
it
it's
doesn't.
somewhat better with reps, but it doesn't seem like there's
No,
still the unpredictable. I mean, I feel like I'm better at selecting the right patients for those, but still it's unpredictable. Whereas TJR, man,
I
people just
feel
get
like
better.
TMJR and discectomy, meniscectomy in the short term, not necessarily long term. I feel like those two, for me in my experience, I feel like those are the most predictable. Like it's unusual that a meniscectomy doesn't get better. Now, how long is it going to last? I don't know. That
Yeah,
part predictable.
but everything that you have up there in terms of longevity and scars and facial nerve injury, all those sort of things, those are all the same or worse, right? For taking out a meniscus. I guess scar isn't.
Maybe not scar.
I don't
Facial
know.
nerve injury, you could argue is a
But
little different
I
because of
think
one incision versus.
longevity for TJR is great. And I think pain relief, predictably great. Um, one of the we're not going in order, are we? One of the misconceptions in terms of this one that I hear is, people still have pain or they'll still have relatively high degrees of pain, which is borne out in the literature, by the way. That the pain relief doesn't resolve; it just gets better. And I mean, that can happen, but I feel like a lot of TJR literature was based off of operating on people who went through surgeries in the 80s and 90s.
You got it. I
Um,
agree with you completely. I
and
think
if you've been through 7 or 8 operations, it's going to be a hard outcome.
exactly. That's one of the overall themes that I always try to relate to people, and people listening, I would want to say is a big misconception. And I find that I think our struggle for TMJR has shifted from what it was maybe decades ago. To me, my struggle with TMJR now is walking the tightrope of over treating versus treating people soon or early. Because in my experience, the earlier you find and identify a TMJ replacement patient and you get them into the device, they do so much better. But that's the struggle. It's like, could we have maybe done something else to avoid getting to total joint replacement? You don't necessarily want to make that leap, but man, the patients that I do this in who haven't had 5 procedures or haven't been in treatment for 10 years, the patients we get into these things early, I feel like open great. I feel like they have minimal to no pain. I feel like they have great quality of life. It's the ones who've been delayed or have had the disasters of previous devices and are just full of giant cells and scar and fibrosis. Those are the people that struggle. And I think you're exactly right with the literature. That's the why it's the way it is because of the way we have traditionally treated patients. They were in failed devices or they were in non-surgical treatment for 10 plus years. Like they have chronic pain. You're not going to get rid of it all.
I mean, I remember being harassed as a resident, being asked how much mouth opening would you expect from a TJR patient, right?
That's another misconception, right?
Literature, you can't get more than 35 out of that, right?
I
Like
went
you'd
back and looked
expect
at
30 to 35, 28,
what do
something
you
like that
see?
would be normal.
What do you see?
What's that?
What do you see in your
Oh,
practice?
now?
Yeah.
Well, yeah, I mean, because there's no reason they can't get back to normal mouth opening at all. I mean,
Yeah.
over 40 is not an unreasonable thing at all. I
I
mean, they
went,
just have to go through PT. You have to have a bit of motivation, but the right motivated patient through PT, like, I don't know why it would be restricted otherwise. I see people, I try to encourage them, but a lot of people find, like once you get over 3.5, you get to 4 centimeters, they're just like, it's fine. I don't need to push it any further. But
well,
man,
that's
I
because
think the
where they're
most I've
coming
seen
from,
is in the
right? Because
50s. Like I've seen some
yeah, because
crazy freely mobile mandibles with TJR in there.
yeah. Well, I mean, it's also where they're coming from, right? If they were at
Yeah.
15 before and you get them to 35 or even 30, like they're ecstatic and they will sometimes say, I'm happy. And, they could probably get more. But yeah, I went and, again, when you said we were going to meet and do this one, tried to look at my patients and I have of this year, like, and I looked only from July on, I have 3 of my patients who are 40 plus. And, they've only, they're only 6 months into their after the
Well,
device.
yeah, because I mean, I think there's been some changes in this field for the positive, just like in orthopedics. Well, probably because there's changes in orthopedics, we're stealing a lot of their stuff. But I mean, this is pretty close to being outpatient surgery. I think that if you just do isolated joints, people could chew right after surgery. Pain isn't, I was reminiscing on this last week actually. When I was a resident, people would stay like 5 days in the hospital. They'd have a PCA. It'd be a big surgery.
Yeah.
8 hours, long things. It just isn't that way anymore. I mean, the anesthesia techniques that we use in our jaw surgery practice, but for TMJ replacement, I think particularly in the future, this will largely be outpatient.
I think they recover better than orthognathic patients.
Oh yeah,
I mean,
clearly yes.
I think they do. I mean, I think when you when the patients have joints and Laforts, their recovery is drastically different than joints only. And
Yeah.
the joints only patients, like you see them in a week, and I'm always, even now, still surprised. I look at them and they're like smiling and talking and opening to 35, and like you're like, I know what I did to you. Like I was there. You were open. I took some stuff out and I put metal and plastic in. Like you're looking, you shouldn't look this good. And they look good and
Yeah.
they're happy.
Yeah, no, I mean, I think the perioperative stuff has definitely changed over time. I mean, I think that comes with experience, but also just kind of anesthesia techniques and everything else. A lot of the planning's good. So,
Well, as we're prone to do, we get to rambling and going off on tangents here. So like if we're going to change the world, we have our list here. So like are we checking any boxes? What do we want to make clear to people, maybe who are non-surgeons even who might come across this? What would they want to know? So we kind of talked about the mouth opening and how that's kind of misconception. And most of our patients actually, I would say most of mine are above 35. Some of them are, it's too early to tell. Some of them are, ankylosis or heterotopic bone, and those sometimes don't do as well in my hands.
well,
But
I was tasked with reviewing our outcomes at Swedish over a 3 year period of time, and we had a couple that their pain didn't get any better. We had two patients that pain got no better. Um, and they were the same two patients that got less than 30 millimeters of opening. There's commonality of those patients. But I think I'm bringing it up from the standpoint of that bad things can happen with TJR. Bad things would be infection, device revision if put in wrong, or it whatever occlusion's off or something like that. Allergy and bony overgrowth. So those are real things,
yeah,
and they seem to be really problematic.
okay.
Have you had a revision?
I have had to revise previous ones, yes. Not, I haven't had to revise any of my own yet,
Like in
thanks.
the perioperative time?
No, mine were like months or years later.
Oh, okay. Yeah, I mean, because I've had actually a couple where I've had to take back. They were both dislocation cases.
Oh,
One
yeah.
was because it dislocated posteriorly, which I didn't even knew could happen actually. It had to do with how much of advancement. I think I advanced her like 4 centimeters or something. Um, and so, I mean, it's unusual cases, but when it comes to surgery, while we're seeing the benefits of this, the downsides are significant. Infection is a big deal. Infection gets people in a tough spot.
Infection is rough, and I've fortunately yet have not had to deal with that. I know my time is coming, but yeah, that's a big problem because you're more than likely going to remake devices, and that's a problem. And yeah, now that what I heard you say, I want to revise my answer. I have had to revise that. I've had someone who has dislocated, and we had
Yeah,
to go back and we had to put them back under GA, put them back in, and then we actually had to revise the Lafort because of that.
because I actually think there's more technique to custom devices than I think people let on. Certainly, that what I had thought coming out of residency and fellowship. There's more nuance to it. I thought there's more nuance to the stock device, but there's just different situations and getting those things lined up in the fossa and watching out for interferences and freeing up the soft tissue and when to take the temporals or not and how to rehab, resuspend muscles, those sort of things. Um,
Definitely.
Definitely, if you didn't get a ton of training, it's worth showing up to, TMJ mini course or spend time at Amos or something.
Yeah, definitely. So we talked about mouth opening, but the other one I hear, I don't know, do you hear this from patients or other referring docs or other practitioners about the lack of excursive and protrusive movements and that being a big deal? Do you
Oh
still hear?
yeah. Yeah, you
I
hear
don't
about people resuspending lateral pterygoid? Do you know about
yeah,
that one?
I don't do that. I don't,
I'm not quite clear the purpose of that one either.
yeah. So I mean, the one group of people I usually do not hear complaints about the excursive and protrusive movements is from the patients. This seems to be a like practitioner problem that they worry
Well,
about.
so
They have to relearn chewing. They say that. They say it feels different, but like I've never had someone say like, I can't move my mouth forward and I hate it. They'll point it out sometimes, but like they don't ever seem concerned about it to me. Do you hear that as a complaint frequently?
I mean, in unilateral cases, I hear about it, the crooked
Yeah.
mouth opening. I mention it to everybody. I tell them about it. I think you can actually regain lateral excursive. Protrusive, I haven't yet to see come back. I mean, maybe I've seen a little bit like a wiggle, but lateral excursive, I mean, it's rare, but I've definitely seen people rehab to near normal lateral excursive movement, which I was pretty surprised when I saw that.
Yeah, I can't recall
Um,
seeing that.
yeah, and I think there's, a bit of training to get accessory muscles involved. I'm sure most people are probably like how we would be after this sort of thing, which, you're doing well, you're happy with it, you just get on with life, right?
Yeah.
But if you really want to rehab, it can be done.
And that's the other thing I always remind the patients, and again, most of the time I feel like I hear this from other docs, is they weren't moving normally to begin with. Like we weren't doing this surgery for fun, like it's not like we took a totally normal, functional, healthy joint and now we've taken away their excursive protrusive.
Yeah, sure. That's a good point.
We weren't starting from normal. Like that wasn't our starting point. So like, and some of those things I just deal with. So I always point that one out. Now, the other thing I'll add, it's on the bottom of the list, that patients hate them. I hear that from time to time, and I have not found that to be my experience. Have you?
Yeah, I don't know if I've heard that one. I mean, I've definitely met people that wish they hadn't gone with TMJ replacement.
Yeah,
Um, and I mean, I think you meet people who have outcomes they don't want to have with that opinion, but it's like really hard to predict that opinion. And what's the alternative, right?
exactly.
And it's I think framing it correctly is the right approach. Because again, in the clear indications of, let's say, bony ankylosis, you're just going to smush mashed potatoes in, right? Like you're just waiting for your teeth to fall out. It's going to be emergency when you get intubated.
Yeah,
So I think from patients that are dissatisfied or have an infection or there's something that's going wrong with it, I think that's luckily a rare patient. I mean, I really think that's low single digits.
yeah. I was trying to think about that as you were saying that, and only one of my patients comes to mind of if I were to like candidly ask them, would you go through this again? There's only one that I could think of that maybe would say no. And that's because that patient's pain, as you were talking about, was they were in pain for so long, had heterotopic bone, could only open like 14, 15 millimeters. Um, and the pain part really did not get better. And that taught me a hard lesson about pain. I told her, yeah, I think your pain's going to get a lot better. I think your opening's going to get a lot better. And she's the only one I could think of that might say no, although her opening is more than doubled.
But I mean, you have to assume there's people that, went to see someone else or
Of
didn't
course,
follow up or something like that.
of course.
Um, but
But
I
I feel like
mean,
that's a small number. Like
I,
I think even patients who maybe their pain doesn't get better, will they still open much better? And I think the other part that can't be ignored is, and it often is, well, your disease is also no longer progressing, right? You don't know where you would have ended up. And a lot of those patients are in active disease and they're comparing it from their final state before joint replacement, but you don't know where you would have ended up. If you're heterotopic bone or you're degenerative joint disease with malocclusion, presuming you didn't get treatment, you're probably headed towards getting worse. And I think that's sometimes lost in all of this thought.
yeah, I mean, it's hard to predict, but I think when it comes to patients dislike, I would say in the context of all the rest of the things we do, I don't think there's any particular increased dislike for TJR,
Yeah.
and probably the opposite of that. I would say on their facial nerve injury seems to be something that people are freaked out about. Um, and I mean, people who haven't had a facial nerve injury in the past, this is another one that's low single digits. I don't think this one's common at all. I mean,
No.
I see temporary weakness for sure. I use on cue catheters. I use pain pumps. But if you use Exparel, probably the same thing. What are you using?
Man, I've been trying to get to use Exparel. I don't put pain pumps in them. I don't like the idea of having something foreign going out near my and going in near my device.
Yeah, no, I agree. I mean, it's just the only thing that's available to me, and they have a long history of utility. But they do cause some
I
temporary
use
face weakness.
bupivacaine and they still do well. I mean, I just at the end of the case, I reprep the face, so I'm not going through dirty skin after doing a Lafort or whatever. Reprep the skin and I inject just bupivacaine with epi,
Yeah,
and they
on cue
still
pump,
get
that
out of
thing
the
lasts for
hospital.
3 days.
What's that?
That thing lasts for 3 days.
Well, not Exparel. I'm not using Exparel. I'd love to use Exparel. I'm just using normal bupivacaine.
Oh no, I know. What I was saying is on cue pump.
Oh yeah.
Um, yeah,
And they usually go home the next day and they do fine. Like
yep. But
I was worried about it, when I first started doing these, but they still do well. I mean, they get out of there the next day.
but
Do
I would say
surprisingly
of the
well.
facial nerve injury, the marginal mandibular, I would say is the one that at least I see. I feel like that's what I hear from other people who do this sort of thing.
Yeah, again,
I've
I'll
met
say
someone with facial nerve.
feel like I'm being a jerk, but a lot of these that I put on here, again, I hear more from healthcare providers, and although I'll say us, us dental providers, I hear a lot of these from the providers more than the patients. I'm sure you've had this too. I feel the phone call from the dentist, the prosthodontist, orthodontist, whomever, of, you're going to ruin this patient's life and you're going to give them a facial nerve injury and you're going to give them these crazy scars. And, I'm like, well, what do you propose as an alternative? Like, we're not doing this for fun. Uh,
Yeah, I mean,
that's
the
low.
fact that there's, like in big cities, there's multiple providers that are doing this as a routine thing, should give some people some comfort.
I hope.
Um, but I don't think it does. So that's the purpose of us talking about it, though, right?
That's
I
the
think.
hope, is that we're going to change the world here today and tell people that, again, I think the patients who need these, need them. And so I think scars and temporary facial nerve injury are not high on their list a lot of times. I mean, would they choose to have less of these things? Of course.
Yeah, yeah, yeah. And it's these sort of things like the downsides is why you want to avoid it.
Yeah.
And I'm very much on that camp. But there's some clear times that it's very useful. I think it's a
Yeah.
very useful tool.
Would you
For
trade 15 millimeters of opening and daily debilitating pain to having a scar that can be seen if someone looks at you from the
I
side?
mean, I would say pain in anything less than 20.
Yeah.
I mean, because like it
You've
pretty
got this
functionally
jaw.
impaired when you can only open 2 centimeters.
Yeah.
And if you have pain in conjunction with that, I think it's because just opening alone, I mean, uh, I could understand why you choose to live with that rather than put
Mhm.
yourself through the risk.
Eventually.
But if you had pain in that, I think rehabbing or using splints or medicine or acupuncture, um, that stuff's great. I think that there's the option exists for TMJ replacement. So
All right, so let's summarize here. So we kind of tried to hopefully explain to people that these are not investigational or experimental. We have over 30 plus years of data on these. So we think that they have good longevity. Now, some of them do have to come out. Things happen. As we talked about, they're not all perfect and pristine and all going to last 40 years. But, as far as we know, well-placed joints and patients without other exacerbating factors are probably going to hold up. What would you confidently tell a patient? Like, hey, I think if things go as planned, you're going to get at least 20 years out of these. Would you?
I don't know why they fail. And I mean, I've seen them fail,
Yeah.
but I mean, there's a patient that I saw that was in that paper actually on the 20-year follow-up. She had tick media devices. And I mean, they broke it a screw hole. And then we just replaced them. She did fine. Because yeah. So I would say, um, longevity of device, in comparison to the alternative, because let's say comparison to a rib,
Yeah.
what is it, 3-year revision rate on a rib is 50%.
I think it's over
Uh,
50 then, isn't it?
I feel like that's true. I want to quote the paper, but
Yeah, I would
I'm blanking on the name.
do it a rib nowadays without a very, like, to me, I'd have to have a very, like, there would have to be an actual, like, exact reason why they need it. Like, I can't even think in my mind of why. I mean, you would have to have some crazy metal sensitivity. I mean, I'm just trying to even envision scenarios.
Yeah, but I mean, like in comparison to let's just compare it to like a dental implant, right? Like TMJ implants, I mean, in many ways are similar to dental implants in success, right?
Yeah.
Like almost always they succeed. Not every time, but almost always. And there's some things that set you up for it. There's some clear indications for dental implants. You don't want to go over the board. I think these are similar topics, even though the implants, I mean, it is a dental implant. It's just kind of like a little bit bigger than a normal dental implant.
Slightly.
But I mean, philosophically, I think thinking of TMJ replacement, even if you don't practice by doing those, is that those are similar. Good
Yeah.
outcomes, good longevity. No real reason to think why they would fail if they make it past a certain window. Um, it's a mainstream intervention. And so I just don't know if there's enough voices these days. Because, in the past, there was a few people that really did a large volume and they were the loudest voices, like, Wolford.
Yeah.
McCurry. And those guys, as they get a bit older, the younger crew just needs to keep hollering about it. So I think it's
Okay.
good that we're talking about it.
What about scars? Do patients complain about their scars? You get a lot
I
of
don't
that.
know. I mean, yeah, there's scars. There's scars in the face. You got a belly scar for the fat graft. Scars, I mean, the preauricular scar, I'm not sure if I've ever heard that as a problem.
No.
I use a tracheal extension on it. And then the retromandibular, I moved it high to the angle of the jawline. That's a little bit unpredictable because, as you change the mandible position with counterclockwise rotation, the angle can vertically. We had someone about 2.5 centimeter change recently at the angle. And so I try to shoot just beneath and behind the angle, but sometimes it ends up on the angle. I like it there rather than the neck, just because if you have it low, then you can see it. So I think the scars that I've heard some negative feedback is when it's low, right?
Yeah.
So
Yeah,
uh,
it's always for the ramus access. Yeah, I'm with you. The tragal, the endoral or whatever approach you want to use to access the condylar or the fossa component placement. I can't remember patients.
yeah, and it's not to say there isn't scar. It's just it's not like a cut on your cheek, right? It's
Yeah,
not like one big disfiguring deal.
yeah.
So
Um,
I think we hit it all.
yeah, we talked about facial nerve injury. Well, I think the facial nerve injury, maybe, again, I would just emphasize is not rampant. We're talking single digits for things that last longer than a week, or whatever most of the time. Some I've had a few last a few months, but can't recall ever having a permanent, complete nerve injury.
I've seen permanent weakness. I mean, in particular, people who've had previous injury, because there's gradation of weakness. When it comes to marginal weakness, that's the one that comes to mind when I think of facial nerve injury.
Yeah.
I mean, there's other nerves that I feel like have about the same problem. I mean, I've seen gustatory sweating a couple times. I think at least three or four now. Um, I don't know. I think from the misconceptions that you have up there, I think the only one we didn't hit was the recovery.
Yeah, and I feel like that's again they recover well, but they do have to do physical therapy. I mean, it's
PT
put in some
key,
work,
definitely.
but like
Yeah,
I think from a going back to life work standpoint, they can actually, again, if we're talking about just joints, they can go back pretty quick. But yeah, there's an active recovery process that goes on for a while.
I uh I got a TDR case coming up in a couple of weeks. Um, and there might be a physical therapist observing that day. I'll see if
Okay.
I can sweet talk her into joining us on our podcast to find out about some PT approaches for TMJ rehab. What do you
Yeah.
think?
I mean, I don't even refer all mine to PT, and I just give them the aura stretch. If
I
they're
think
struggling,
PT's hit or miss on whether or not in the world of TJR surgeon practice, it's kind of hit or miss practice. But I'm a big proponent of PT. So uh, but yeah, I mean, in recovery, I don't know what you tell people. I tell them generally it's going to take 6 months before they act normal and they don't think about it anymore. But time off of work is like a week, maybe
yeah,
2 weeks. Um,
yeah, I would
they
say
should be
if you told
back
a
to baseline pain in a week.
yeah,
If they came in with pain, they'll be back at that level pain by a week.
yep.
That's not perfect, but roughly it seems like it's right.
Well, I think
And
that's worth emphasizing because again, I think in the world of the dental world, outside of, head and neck surgery, some people view this as one of our, bigger surgeries or a bigger deal. And I think that's something that is worth repeating that if you told a TMJ replacement only patient that they had to go back to work at a week, I think the vast majority could do it. And I think some could even go back sooner.
yeah,
It's not a 6 month recovery, or you're not laying in bed with needing home nursing for,
yeah. But I mean, some people do have more pain and those sort of things. Like it happens.
there's
But
outliers.
I think the recovery from surgery is more like orthognathics is like a week or two. And then after that, it's kind of like rehab and PT, getting occlusion right. Because it tends to be, the posterior open bite tends to open up after like a week or two. And then that starts settling down. It's just kind of wiggly joint, making sure they kind of follow the process. So that's why I think in terms of long hospitalization, teeth wired shut, all that sort of thing.
No,
Uh,
don't
I
wire
think
people
those
shut anymore.
misconceptions should be put to rest.
Yeah, definitely aren't wiring people shut anymore without there being a problem.
Yeah.
I don't think I can't recall wiring one of these patients shut, but I mean, again, it's a valuable tool should the need arise.
Yeah, I mean,
Yeah. And then I would
I
also say,
think
again, it's not a last resort only. Like, I don't think people should look at it that way either. Like, it shouldn't be your first line treatment outside of tumors, ankylosis, like we talked about, et cetera. But, I think, again, our research is starting to show it, our practices are starting to show it as younger patients. People are putting these in kids, people are putting them in teenagers because of the longevity and how well they do. I think viewing this as exhaust everything else, put the patient through multiple procedures and years of treatment, I think that idea has to go away if we generally want our patients to get better.
I agree. Yeah, no, it's you didn't even get all that fired up. I was expecting you to get just excited. I should have like poked you a little
Well,
bit.
I told you what I did with my kids last night, so I'm a little tired.
Yeah, I hear
And
you.
I'm also aware that this is forever going to be on the worldwide interweb, and anything I say could always come back to haunt
Put
me.
your best foot forward. I hear you.
Yeah.
That's good.
And
Yeah, no,
look,
it's a good topic. I think there's a lot of people out there that could help really benefit from these things. And I know you're the same, but I'm a big proponent of surgeons practicing in this world. So look forward to the young guys kind of coming up and doing it.
all right. Well, thanks for joining me again, Sam. Again, this is the Down Fracture podcast for talking jaws. Feel free to email us prospective topics, cases, things you want to hear about. Downfracturepodcast@gmail.com. And till next time, Sam, I'll see you later.
Mike, catch you later, man. See ya.
Yeah.